watching Cablevision, Channel 31, local origination programming, your hometown network.
Welcome to Mind Over Matter. It's a pleasure to have Dr. Merle Orren, who is a psychologist who specializes in neuropsychology. And today we're going to be talking about head injuries and the psychology that kind of follows head injuries. So I thought perhaps we could talk a little bit about head injuries, brain injuries, and why it's so catastrophic.
Well, thank you. It's a pleasure to be here. This is a population I've worked with for about 16 years and have found it very challenging and interesting and moving to work with many of these clients. I think the reason why brain injuries are so catastrophic has to do with the scope of brain function and the fact that every experience, every action, every feeling that we have is mediated through our brain. So when something goes amiss in the brain, our lives are pretty disturbed. All our biological rhythms, our physiological equilibrium is controlled by the brain. Our ability to learn and adapt to the environment is also a brain function. And as you can see, just a disturbance in an organ that has such a large scope in our life would be a big adjustment for us to...
But isn't it, for I suppose the reasons you're suggesting, isn't it pretty well protected? I mean, some of us have pretty thick heads.
Well, actually, a lot of the injury occurs by the movement of the brain within the skull, and that it's not just a question of a fractured skull, but as the brain is accelerated or decelerated within the hard skull, that some of the tissue tears and rips, and the nerve fibers no longer can transmit their impulses. There's some bleeding within the brain as a result of those mechanical forces that can occur without a skull fracture at all. Indeed, some of the people who even have a very severe whiplash that occurs when they're sitting still in a car and then get violently thrown forward does not come from the impact of the head on the dashboard at all, but in the case of a whiplash, just from the movement of the brain within the skull. So you don't actually need to have direct impact to the brain or the head.
But is it fair to say the head is pretty well protected, and it takes a certain amount of trauma to get an effect like we're talking about?
I think to get some of the severe generalized motor problems and speech problems, I would say that's true. But I think what we sometimes see in people that have had milder injuries that don't have physical repercussions, they often have subtle deficits in their ability to process more than one thing at a time, in their speed of processing. It's like having potholes in a superhighway, and by that I mean you might have little tears in the axons, the nerve fibers that transmit information throughout the brain. And they might not show up on a CAT scan or an MRI, but as our imaging tools get more refined, we begin to find that there are little evidences of torn nerve fibers, and that some of the subtle deficits in attention and processing that occur with the milder head injuries are due to that.
So what are you likely to see in mild? We'll
in
talk
a mild
about
brain
other,
injury?
Yeah.
You would see deficits in handling multiple tasks at one time, deficits in speed of processing, and they can be shown on in the laboratory or in the neuropsych testing situation on complex tasks in which the person has to keep track of two different streams of information at once, or in rapid shifts from one task to another. And in real life, there are many situations. We had a client with a traumatic brain injury who did fine in his trial job at a store, because in the trial part, when he was receiving training, he did first one job and then another. So he either was stocking clothes onto the racks, or he was answering the phone, or he was doing the cashier's job. But when he actually started his employment, after he had been there for a while, he was asked to cover all those jobs. So when he would go to answer the phone, he would sometimes forget that he was in the middle of putting clothes on the rack. And he would forget to go back to it. So it could be something pretty subtle, having to do with multiple tasks or switching tasks, remembering to go back, picking up your train of thought. Some people with mild brain injuries, you can notice in their conversation that they will go off topic a little bit and have trouble returning to topic. So it's higher level organizational skills with the mild brain injuries and what we call multitasking.
So it's not a dementia, though. It's in a technical sense?
It's not a dementia because
No.
it's not generalized to language per se, reading, comprehension. It's not a generalized loss of cognition. It's really very specific to high-level attentional and organizational tasks. I think the problem some people have with mild brain injuries is that they look perfectly fine and are expected to perform up to a certain level of which they may not be capable. One of the things we're learning about mild brain injuries now is the effect of multiple mild concussions, and there's been a revamping of high school sports guidelines for coaches in terms of the soccer and football players, about how many times they can be returned to the field after getting what's called a ding. So we're beginning to look at this very closely now. One of the things about mild head injury that we've learned is that often the cognitive effects of this are not seen until the brain is challenged, as I said, by a very complex task. But it was first noted when people with mild head injuries tried to perform something at high altitude, that all of a sudden they began to have trouble with things. And as I said, having a series of mild head injuries is thought to have a cumulative effect.
Why high altitude?
I think because there's probably less oxygen available,
Oh, okay.
and it's a stress on the brain. It's the equivalent of having a complex task.
Now, in terms of tasking, too, is like new learning a bit of a problem for some of these people?
Yes, new learning, especially if it's a lot of material or if there's interference built in the material. For example, trying to learn two sets of instructions that might have some similar wording. The words would interfere, and then recall, the person might confuse them and recall one instead of another. Or just having a list or a paragraph of things that's very long. One of my clients was a very bright woman who was a teacher at a private school, and she just had a hard time following the flow of the meetings back and forth. Even though she was a PhD, her intelligence after her brain injury tested very high, and she seemed to be functioning fine in very structured conversations with a question and answer, a question and answer. But in the normal flow of conversation, where she had to follow a point for a long time, she would sometimes lose it. And it distressed her a lot because she was very invested in her intellect. She was very invested in her performance in her job. And I think that one of the things is that sometimes it's not the severity of the injury per se, but the mismatch between the person's job context and what's important to them and their performance.
Now, for that particular person, for example, if I were in the room, would I notice that she was having processing difficulties? Or could she hide it?
She was more critical of herself than other people. It may have been one of the psychological effects of her accident that she was very worried about it. She may have had some objectively mild deficits, because when I tested her on one memory test that required that she recall a long paragraph as opposed to a word list or word pairs, although she performed pretty well on that, it was much below her other abilities. So her other abilities were quite superior, and on that particular test she was average. So relatively speaking, she did show some problem with that. In a room full of most people, she would seem fine, but she noticed that it was missing. It bothered her, and she became very self-critical, very anxious, lost her confidence, and of course then it all starts to spiral.
Well, we're going to take a break in a few minutes, and maybe we can talk about the course of what happens to people, what the range of symptoms are. Very briefly, though, before we stop, because we've got about a minute, what about roller coasters?
I don't know that, but I've read now that people are beginning thinking now that there might be a drop, there might be a movement of the head. So I think if you were very cautious and conservative and worried, I would stay away from them.
Well, especially some of the newer ones.
Yeah.
What about boxers? Do you think there are any boxers that escape brain injury?
Well, that's interesting. I mean, certainly there's the syndrome that affects boxers. I don't know if there's any that escape, but I would say that the constant pummeling, both in training and in the fights, according to what we know now, would be pretty sure to produce some sort of cognitive deficits. I don't know how many boxers have been tested before they began their careers, but I'm sure now, at least in terms of college athletics and amateur athletics, that there will be some attention to that. As I say, this knowledge is now just gradually seeping into athletics, especially for high school and college age.
Well, after the break, maybe you'll tell us about some of the new data, and then maybe we could look at the range of symptoms and the course. Thank you. So we'll take a break.
Kids, over here. Nobody's looking. You want to go down backwards, or better yet, head first? Kind of like you're flying.
Talk about flying. I'll launch you halfway to Aunt Nelda's house.
Don't listen to those shrimps. If you got the guts, I'll show you the whole playground upside down.
Oh, he can't even move. I dare you to try and hold on to me.
Hey, kids, I got 2 words for you. Human catapult.
Oh, stop your squeaking, you rusty.
You want some of this rust? Come on, I'll give you some of my rust. Come on, I got rust.
Last year, 500,000 kids were injured at playgrounds by the power of their own imaginations. Please supervise your child. For a free brochure on preventing playground injuries, call the American Academy of Orthopedic Surgeons toll-free or visit aaos.org.
This doesn't look fun to you. I'm having the time of my life here.
Edgar Degas had eye problems most of his life. Claude Monet had cataracts, yet he continued to paint. And even after Georgia O'Keeffe's vision was permanently impaired, she went on to create masterpieces. These artists did not give up because they had trouble seeing. They just made the best of what vision they had. So can you. Call for a free booklet that will show you how. 1-877-569-8474.
You might think by exercising, eating healthy, and not smoking, you can prevent heart disease, right? Wrong. Lifestyle changes can only improve your odds, not prevent heart disease. But why worry? Heart disease is not a problem for women. Wrong again. 1 out of 2 women die from heart disease. It's the #1 killer. Call the National Heart Foundation at 437-2423. Get the truth.
Okay, well, maybe, Merle, we could talk about a range of symptoms, what you're likely to see following a closed head injury, and then maybe also talk a bit about the course of recovery and adjustment.
Okay. Well, first, maybe we could start by just looking at the kind of effects that follow from actual tissue damage in the brain, what we call the organic consequences of the injury. And those fall into three categories, and they're disturbances of mood, disturbances of control, and disturbances of cognition. And the disturbances of mood are the same types of mood changes that you might see in any mental illness. In this case, we know that they have at least partly an organic cause, and those would be to see an organic depression due to the disruption of those parts of the brain that have chemically to do with depression or anxiety. Sometimes you just see an instability of mood where someone can just very quickly change from a state of being calm and neutral or even a little happy into a very irritable mood, or vice versa.
Something that wasn't present before the injury?
Sometimes, right? Especially early in recovery, that kind of lability or quick change. But in some cases it persists. And then on the other hand, there are people who almost become, in terms of their mood, very flat and not activated easily, a little bit indifferent as to their situation. Less frequently, people can develop an organic psychosis, which is probably some combination of certain mood changes with cognitive disturbance in interpreting the world. But those seem to be less common than just the depression, anxiety result. In addition, and somewhat related to the mood changes are just disorder in the control process of the brain. I mean, normally our behaviors and our emotions are fairly regulated in that higher centers of the brain make sure that our emotional centers don't lead us into uncontrolled behavior. However, when the frontal lobes of the brain are damaged, or the nerve fibers that connect the frontal lobes to the emotional centers of the brain, when they're injured, the regulation inhibition is somewhat disturbed. So the control problems that come up are of three kinds. I call some behavioral excesses. These are the kind that get our attention because people might act out. They might be very disinhibited. They might be aggressive and threatening to other people or to themselves. And those are the ones that usually get our attention in a crisis or emergency situation, or a family member calling the police, or someone at a store calling the police. So you could see how that would be very detrimental to any sort of family life or vocational success.
Like what? Can you illustrate? Like what might call someone, what might prompt somebody in a store to call the police?
Okay, well, I could give you an example from one of my cases. It was one of my clients who I have done counseling with for about 7 years, and she had a very significant brain injury. She has some physical limitations and many cognitive limitations, and she lives independently by herself in an apartment in Cambridge. And for her, the most simple errand that we do is very involved, because she walked down to the bank, and that's an effort, and then she'll take her money and go to a store and get something. But what happened one day was that she walked down to the bank. She doesn't have any credit cards related to her injury, but and her overspending. But she walked out to the bank, took out some money, then walked another half mile or 3/4 of a mile to a pharmacy to get some medication. And discovered she didn't have enough money for the medication. The store was going to be closing soon, and she asked if she could have some credit, and the woman behind the pharmacy desk said that she couldn't have the credit. So she was just, having expended all that effort, having felt very disabled in the whole process, she just took her cane and lashed out at the woman who called the police. And so it was the provocation of maybe having some real genuine feeling of disability, having put forth the effort, being fatigued, and I think just having a low threshold for that kind of thing to happen.
So many people, because it's certainly been my experience as well, the awareness of disability is really key.
Yeah.
Yeah.
Yeah, and we'll talk more about that later, because that is a big piece of it. But I think she really, she's someone whose moods change very quickly, and I think that there's also an organic piece in her case as well. But certainly the feeling disabled is a big contributor as well.
Of course, the pharmacy, they could have given her a few days' supply. I mean, a number of ways they could have been sensitive to the effort she had expended and her need for the medication.
Right. That would have been helpful. And maybe it might have gone that way, but I don't think it got that far. But the initial response was not the one that, it was very quick. Yes. And I've seen her turn in a flash, so I know that it can happen. So that's what I mean by threatening and a quick change. So those are the behavioral excesses. Now, the behavioral deficits don't get your attention in the same way, but they're as interfering to a person's success in life. By the behavioral deficits, I mean is failing to initiate a needed action or failing to follow through with something that already has been initiated. And it's almost as if people's motivation or maybe their sense of reward has been blunted. But it seems that the chain of events, the chain of behaviors that are necessary to proceed in a goal-directed way, that the motivation for that is somehow undercut. So,
I mean, now the motivation.
Or the emotion that drives us, yeah. Why? Because I think some brain centers that are important in appreciating reward or appreciating even an aversive situation are affected. And just a little bit of a sidelight, but I've seen some of my patients who may have a terrible sore in their foot from a shoe or a brace rubbing incorrectly, who don't even feel the pain. You wouldn't know it was there unless they happen to take off their shoe and sock for another reason. So if they're not feeling actual physical pain to an open wound, maybe the sorts of rewards and pleasures that motivate our behavior to go through a long sequence of actions for some reward, maybe it's just not as intense.
Okay. So there's like a disconnect between the means and the end.
Right.
Okay.
Right. So those I would call the behavioral deficits, and they do interfere with people's maintaining a job or pursuing any sort of goal-directed or pursuing a goal that takes lots of steps. Okay. And finally, the third category I would just call behavioral mistakes. Behaviors that are not wrong or right in and of itself, but the behavior is just generated in the wrong situation. A good example might be a client who's new in a job and may start socializing inappropriately with his or her work peers during working hours, when the same sets of behaviors outside of work might be fine, but it's failing to deploy the behaviors in the right setting. Nothing wrong with that behavior, but
so they've
just
lost
don't do it at work.
Kind of like an editorial skill.
Right, and the discrimination and the editorial and the self-censoring and the deferring to later. Again, it's part of goal-directed behavior, but maybe just not remembering that they're not supposed to do that. So those, I would put the behavioral control. And finally, the cognition piece, and it's hardly any, there's hardly any cognitive function you can think of that is potentially not affected. Not everyone's affected the same way, but for example, memory problems are very common, and memory problems can produce agitation in someone who's confused and doesn't remember what happened a little while ago. If the memory problem is severe, it could produce a little paranoia. If you think someone's taken your wallet or your papers or whatever, you can't find it. Sometimes simply failure to attend to what's relevant in a social situation may mean that you focus on the wrong thing. You could misinterpret someone's facial expression, someone's tone of voice, not quite getting all the meaning of what they're saying. So there's a lot of fertile ground for interpersonal problems in some of the higher level cognitive difficulties. Also just reasoning and being able to think in the sense of, if this happens, then that, or if I do this, then that, or what if, kind of the imagining, the thinking through and anticipating problems.
Well,
and
like
so
reading
people,
a book, is that?
Yeah. Some people can read books, and some people find that they can't remember from day to day what's gone before, so they maybe have lost interest in that. But I have the same client who, with the cane, went after the pharmacy personnel. Even though her memory and her attention isn't good enough for reading, she's actually quite a good writer, and she is compiling some essays about her situation and the changes in her life and her life before and her life since. And it's not only a great cognitive exercise, but it's very therapeutic for her. And it's been a project that she can sustain long term. And she has someone helping her with that, a writing.
Does she write, or does she use a computer?
She uses a computer.
She does.
Yeah.
So she's able to do that.
She can use the computer, yep. And that is, because she's writing essays and not a book, she can finish an essay in a couple days, and it's done, and it's part of it, and move on. Yeah.
That's interesting.
So.
Well, I think we'll have to take a break, and then maybe we can move a little bit after the break into some of the psychology of all of this, because we both know it's quite profound.
Right.
So we'll pick up on that in a minute.
Okay.
Thank you.
All right.
As an astronaut, I've seen some sights I will never forget, and I'm looking forward to seeing even more. Think of all the beautiful things you wouldn't see if you lost your sight. If you're over 60 or an African American over 40, vision loss from glaucoma is a real possibility. But glaucoma can be treated and the risk of blindness reduced if it's detected early enough. A thorough eye examination by an ophthalmologist or optometrist is necessary. Get one every 2 years. Don't lose sight of what your eyes mean to you.
A bright smile is a great asset, but as you get older, your teeth can naturally darken, no matter how well you care for them. As you age, the outer layer of enamel on your teeth gets worn away. As that enamel becomes thinner, it reveals the darker tissue underneath at the center of your tooth, where the nerves and blood vessels are. Meanwhile, your teeth may stain and absorb a darker tint from what you may eat and drink, such as tea, coffee, and red wine. So it's still important to brush and floss regularly. If you want whiter teeth, you could consider tooth whitening. Ask your dentist to determine if you are a good candidate for tooth whitening, to inform you of the various procedure options and what to realistically expect. Remember, no matter how old you are, some of your most valuable assets are healthy teeth and a warm smile. For the ADA Dental Minute, I'm Dr. Maria Lopez-Howell.
Fruits and vegetables. You know, you ought to eat more of them. Yeah, eating 5 servings a day is a great way to stay healthy. You'll feel better and you'll have energy, too. Yeah, that's what the people from the National Cancer Institute say. After all, you are what you eat.
part because the psychology of head injury is quite interesting and pronounced, so maybe you could make some comments about the psychological impact on these individuals of head injury.
Well, the psychological impact is huge, and in a way it's the place where psychiatrists and psychologists and case managers and counselors can make their biggest impact. The reason it's so huge, in addition to what I said at the beginning, is just the whole scope of the ways we depend on the brain is huge, and because new learning is affected, is because the course of recovery from brain injury is usually best at the beginning. And then by that I mean people's recovery, both physically and cognitively, tends to be pretty rapid at first, at least once they come out of a coma. It tends to, for most people, it progresses pretty quickly. It progresses quickly at a time when they have lots of medical supports. They have neurologists and physiatrists and physical therapists and occupational therapists. They have a whole rehab team, social workers, psychologists. Then,
well, wait a minute, excuse me.
Yeah.
They have a team. How do they get to having a team? I mean, it must be many people with mild head injuries who have nothing, maybe not even an awareness that they've got a problem.
That's true. I'm talking about, right, you're absolutely right. And I'm talking about in taking a severe case, that someone with a brain injury would go through acute care hospital and then a rehab hospital, during which time the families are getting a lot of support and the client is getting a lot of treatment and some progress is being made. But you're absolutely right. Someone who's had a mild brain injury will often be discharged from the emergency room without even a precaution or a warning that they might experience some disorientation or fatigue or maybe a little confusion, impulsivity. And those people, I think, are done a real disservice because they're not really prepared and they're not really given the follow-up they need to kind of catch these things early before they spiral into a loss of confidence, anxiety, thinking that they're crazy because no one's really prepared them for some of the... so you're right. I think we should divide it into people who have had severe enough injuries that they're clearly, meaning physical, that they're clearly in some sort of rehab support system, and the people whose injuries are not recognized because they tend to be cognitive and psychological and invisible. Okay, to the
So we'll come back to it later, but here I think you're talking in part about the State Head Injury Program, SHIP, and I think there may be other services you can tell us about, but obviously I guess the immediate question before we move on is, is as they go through the acute care and then the rehab hospital, is there a referral mechanism? I mean, how do eventually cases get referred to you and or to SHIP?
Okay, well, it used to be that there was a better network at discharge from a rehab hospital to getting community-based supports. The whole telescoping of all our health care into very short little bits has affected what brain injured folks can get as they're discharged. There are both Health South through Braintree Hospital and what used to be New England Rehab Hospital, they do have some cognitive rehab programs which will help with some of the higher level cognitive skills above and beyond speech therapy and physical therapy. Or they may take speech therapy, physical therapy, and occupational therapy and perform them in the community with the client. So, so there are some cognitive rehab programs for people whose insurance will cover that, and I think Mass Health will cover some of this.
Well, let's get back to that later. Let's go back to the psychology. I'm sorry I interrupted, but
that's all right.
You know, I think you know I'm sure members of the audience would be a little curious about what triggers sort of more interventions, and maybe we can close with that.
Okay. Well, having mentioned in the last segment about some of the loss of cognitive ability, control of mood, and just control of behavior. The repercussions of that is that people might lose their whole status in life in terms of their ability to perform their previous job or any job, their role in their family. If they don't lose their family altogether in terms of a spouse, they may just lose their role as a breadwinner, their role as a parent. So they begin to feel a little useless, maybe without being able to articulate that. And that's pretty devastating. Their own increased dependence in some cases for transportation, in some cases for self-care. And then over time what happens, I think, is decreased social contact with anybody because their friends, their peers move on. The help that the extended family was able to do heroically sometimes for the short term can't last, can't go on for years and years. But this particular injury does have repercussions for years and years and years. It may improve, but in most cases it never gets all better. So there's always a psychological feeling of falling short, either from one's own expectations or objectively from their actual performance level at home or at work.
Now, just to be thorough, I mean, would the psychological response be somewhat different if it were, say, a stroke with some residual deficit, cognitive deficits from the stroke?
Well, my experience with stroke, and I'm not an expert on it, but is that people can get very depressed as a result of their strokes. The other side where people are really maybe very frustrated and angry, I haven't seen quite as much. I don't know if it's because the population is older or the strokes are very circumscribed. Well, erase that. No, I was going to say strokes are very circumcised in the brain, but it doesn't mean that their effects are very circumscribed. So sort of the heat that I feel with some of the traumatically brain injured folks, I haven't noticed so much in some of the stroke patients I've worked with, but it's not so much the population I'm familiar with. The other thing I think is that over time, I think research studies have shown that actually people with traumatic brain injuries themselves and their families get more depressed over time with the realization of the permanence of some of the effects and also the uncertainty about what's going to happen to their loved ones who have had the brain injury. We've had this great disguise in a way over the last 20 years in the sense that the first group of traumatically brain injured people who were severely injured who have survived their injuries because our emergency medicine is very better. That group have been taken care of by basically their parents or sometimes a spouse during that time. And I don't mean taken care of like they need to be, everything, but oversight,
support,
financial management, transportation sometimes. Well, now those parents are getting old themselves and ill, and the question of who is going to provide the oversight for an adult who in some ways is functional, who really doesn't need to be in an institution anyway, but someone is going to need to manage the money and help coordinate certain medical appointments that the brain injured person might not be able to do on their own. So we've had this big kind of honeymoon period, but I think I can see in some families that I've known for a long time that mom and dad are in their 70s, and unlike I think the MR population, the mentally retarded population, and some of the mental health population whose families have been a big political force and lobby group through these organizations for a long time. I think we haven't done that yet very well for this population.
Because the MR population have had a lifetime to prepare, whereas the head injured people sort of have gone along, and then there's an abrupt shift in,
Right. So I see this, so all these things I've mentioned is of course, the wear and tear on everybody, and not only the person with the brain injury, but often their families are very in need of a lot of psychological support. Any sort of case management help to take some of the problems and help with them is greatly needed. I think in terms of counseling and psychotherapy, well, I call it counseling instead of psychotherapy, because I think what the brain injured client needs help with is very practical problem solving. Let's look at some of the options. Let's think of ways of reframing this and looking at it differently. And that is an ongoing need. I don't see it really being finished, but it's so helpful to be able to help a client rethink something and help them explore some other alternatives and even go with them to help solve them. It does fill a big need, and even though it's not looking at a traditional change model in psychotherapy, it is a very important support in an ongoing way for the clients. And some of the clients that we provide services to, I think we have for a very long time, and we don't foresee ending those. We wish that some of our clients who we can provide some service to could have more structure and more community. I wish there were more residences that would allow our clients to go in and out of the community as they were able to do volunteer work, to do jobs if they could, and to provide a community where there would be people around. Sometimes I feel that that the counseling and case management that we do is just like a drop in the ocean. So, but I think there are great psychological needs, and one of the cases that maybe we could talk about a little bit is that I could discuss a man who had a pretty mild brain injury, but whose challenges to himself and the challenges inherent in his job created a very big mismatch in his head. And
maybe with that, we'll take a break, and maybe we could pick up with the case and then talk a little bit about interventions and where we can go with trying to be helpful. Thank you.
Okay.
Overgrown bushes and shrubs are more than just an eyesore. They make perfect hiding places for burglars. And they can keep you from seeing the world around you. See what you've been missing. By trimming back bushes from your windows, you can deter thieves and live safer and more independently. For more safety tips, call AARP Connections at 1-800-731-4447.
Wherever you go, you see the signs. A new century is coming, and with it, 1,000 questions. Will there be peace? Will your family ever be in harm's way? Will a small town in Texas be hit with a hurricane? Will your daughter ever need a new kind of blood treatment? Will that nice man who hands you the paper ever need a hand to hold in a time of need? We have no crystal ball for the world that awaits. Just one promise. We'll be there, whether it's in the eye of the storm, in your darkest hour, in your time of need, or in the light of day. We'll be there.
Can you name one thing that we do in caring for the guinea pig?
Children are fascinated by the wonders of the natural world.
Lettuce, okay.
Because the child you interest in science today may save your life or your world tomorrow.
Everything's gonna be okay. You're gonna be fine.
So inspire tomorrow's scientists today.
I'm gonna need an EKG and an IV.
segment then. Maybe you could tell us a little bit about that man, and then we could perhaps then move on to intervention and what the state head injury program is able to provide, what the other services are.
Well, this gentleman, when I first tested him, and it was a number of years ago, and I'm not in any contact with him now, he was the first person that really brought home to me that it's not necessarily the objective severity of the injury, but really, and so it's not just the severity of the deficits cognitively, but it's what the functional significance of the deficits are for that person in terms of what life expects of them, and what the psychological significance of those deficits are for that person. So this gentleman was a very self-educated man. He didn't have a lot of formal education, but he was very smart. He had the reputation of being the best foreign car mechanic in New Hampshire. He had his own, no, he didn't have his own shop at that point, but he was a sought-after mechanic, and he had an injury in which a car or an engine fell off a lift, and it hit his head in a way that he wasn't unconscious for a long time, but he was pretty stunned. It was also probably very traumatic. I think he had a lot of, he might have had like a post-traumatic stress disorder that went with it. But he did have some mild motor problems after that injury, and he definitely had some cognitive problems. They weren't really severe, but he was forgetful. It was hard for him to take in a lot of information quickly, and he was also extremely anxious about his situation. He had a wonderful employer, and I was working at a facility at the time where we did an assessment of him and provided him some feedback about what his cognitive status was, because he was quite worried about it. I was able to tell him that he did have some attentional and memory deficits, for which he was very grateful that someone was able to document what he had been complaining about, in which some of his doctors had kind of, no, look, you're fine, you're walking around, you're speaking. Right. So he actually said, thank you, because now I know I'm not crazy. He had a wonderful employer who took him back to work, but who unfortunately really didn't modify his work schedule enough, didn't really provide a little temporary supervision, because what happened was he did make a few mistakes. He put a tire back on a car and didn't quite tighten all the lug nuts. And when these were pointed, fortunately no one was hurt, but when the customer came back with the car, I think then he got totally anxious that he was going to cause someone severe injury. And he went into one of these downward spirals where his anxiety and depression just made his cognitive problems even worse. And there was also a lot of irritability at home. I think he threatened his son at one point. And he fell out of my knowledge of him. I hadn't heard anything about him. As I say, he lived in New Hampshire, and the last I saw of him, I was at a disability hearing with his insurance company and just telling them what I found and what I thought was going on. About 5 years later, he resurfaces to my attention that what he did was unfortunately, he became divorced from his wife. He went down to Florida, and in his case, the best thing was to get out of the situation that was making him very anxious. And he did a course of study in diesel repair for boats. He took a long time to finish the course, but he got a lot of satisfaction in having passed the test and prepared for a new way of supporting himself. And in his case, because he didn't really get very good support when he went back to his original job as a mechanic, and a lot of stimuli then became very anxiety-provoking for him. For him, perhaps it was the best thing to start something new, take it from the beginning, take it very slowly, and he did pass this certificate for being able to service diesel engines on boats in Florida, on recreation boats in Florida.
So now does that reflect a style, an approach, an intervention for others?
Well, sometimes I think people have to be prepared to maybe start something new. And sometimes it takes a little bit of experimentation to find the right level. One of the one of the truisms in brain injury rehab is that people probably retain their old learning better than it is to learn something new. The situation I just told you was a little bit, didn't fit that very well because of all the other anxiety-provoking things that went along with the old job. But I'm thinking of another gentleman who had a pretty severe brain injury, and when it was time for him to go back to work, and I was consulting to one of the employment programs that was working with him and providing job coaching for him, he went back to his original job based on this hypothesis that he should do better in something he knew. And the job was, he was doing troubleshooting for an electronics company, and he knew he had done that for a while, and we thought, well, let's give him a try back in his old job, and his employer was willing to try it out. It turned out that job, even though he knew it was too complex, there were too many decision points, too much attention and vigilance required. So he was gradually doing worse and worse. Unfortunately, because there are certain labor laws that require a certain criteria before you get fired, he was actually getting raises because he was able to stay on the job long enough till he totally bottomed out. But the next job, the employment service was still working with him, and then they tried to get him a job doing photocopying for a big environmental company. And the photocopying was also pretty demanding. I mean, you have to keep track of which copies are going both sides, which are just one side. Sometimes you have to juggle two different jobs at once because a fast order comes in, ASAP, get this one done, so you interrupt that. So actually that turned out to be too hard for him. The third job that he had was one that he would have rejected at the outset if it had been recommended to him. This job had to do with just cleaning, doing maintenance and custodial work at a Staples store. And it was a job that he still needed cue cards to do it about which floors to wash at what time, what order to go in, how to clean the buffer. And although he would have rejected that job at the outset, the job was within his abilities so that he didn't have to strain to do it. He could spend some of his energy socializing with the other people that worked there. He didn't feel like if he had a bad day that he would totally blow the job. It's almost as if the level of the job had to be within the range of his ability, and by that time, having gone through two other jobs that really stressed him out and that he couldn't do very well, I think that he found some satisfaction with being able to go to work, socialize with the other people, get his paycheck, and not have to worry that he was going to fail.
Now, reading between the lines, because I do a lot of traditional things in non-traditional settings, psychotherapy helps someone like this sort of give up the old self and get acquainted with the new self?
I don't know if psychotherapy would have helped this client. He was getting counseling all along. His job coaches were vocational counselors, so they had some mental health training. And for him, just actually having a successful experience for his particular style, that seemed to be more helpful to him, although he did certainly get counseling from those people. Some people really benefit by the counseling because they like to process, they like to review But again, I think you have to look at who you're working with. Some people either are not really articulate themselves and maybe wouldn't care to have a lot of words around their experiences, and other people really like that and benefited by it.
But even like with elderly, but I mean, very often there is a grieving that goes on, and I think to the extent that we can figure out innovatively how to help people grieve, we promote their adjustment to these very significant losses.
Right. I think that's true. I think that maybe having those counselors even as job coaches with him and helping him process if he had a bad day, you know, or helping him adjust to trying a different job and looking at maybe whether it's whether he saw it as a loss of status or not. I think having those people go along with you, but I think you're right, sometimes it's not traditional. Sometimes whether it's writing essays for the book that you're going to publish, or whether it's one thing I did with this woman with the cane, who's also writing the book, who struck out at one of the pharmacists, but she has some physical disabilities, and I accompanied her to the Axis Dance Company, which is an integrated dance company which utilizes dancers in wheelchairs along with able-bodied dancers, and it's integrated into a very beautiful artistic performance. After a while you lose sight of who's disabled and who's not, and in fact even in the choreography, the dancers in the chairs come out of the chairs and the able-bodied dancers get in the chairs or use the chairs, but it's done in a way that's not at all trite. And it was a way of taking a disability and totally obliterating the difference, or even turning it on its head. And that sort of taking her to see that. In fact, it was the second time she asked to go again. Is what I would call like an innovative thing that she really, you know, I think she really absorbed it. Whether it'll keep her from having outbursts or grieving some more, I don't know. But it was something that I think she'll remember and seem to like.
We do have to stop. I'm sorry, we could go on for hours, and I apologize for that. No, because it's a wonderful topic, very interesting. On behalf of the Norfolk Alliance, I want to thank you for being here.
Well, thank you for having me.
Really appreciate it.
It's my pleasure. Thank you.
Thank you.
So, anyway,
keep talking, because now the credits are rolling.
Okay.
So.